So without further delay, let's start the discussion. So the first question that I've included here is, this was asked in this NEET MDS examination, and the question goes like this. An image depicting severe decay in all the upper anterior teeth has been noted. A 3-year-old child's mother presents with this concern. What diagnosis would you consider for the child's dental condition? So here, what you have to look for, the important clues in the question is, the first one is the child is 3-year-old, right? And the second clue here is all the upper anterior teeth has been decayed. Okay, so the answer for this question is severe ECC. So ECC, like we know, it's early childhood caries. And what is ECC? ECC is the presence of one or more than one decayed missing teeth due to caries or decayed tooth surface in a child of 6 years or younger. Now, before, the definition was 71 months of age or younger, but in 2014, AAPD has modified this definition into 6 years or younger. Okay, so the term early childhood caries was as such given by Davis. And the definition is the presence of one or more decayed, which can be non-cavitated or cavitated. Then it has to be missing, but only due to caries, not due to any other reasons. And filled tooth surface in any primary tooth in a child of 6 years or younger. That is the new definition. The earlier definition was 71 months of age or younger, but it was modified in 2014. So even though the early childhood caries is multifactorial in etiology, that is, many factors play together. Many factors play together to cause the early child manifestation of early childhood caries. But one of the most important causes microorganism, which is mostly Streptococcus mutans. Okay, so this Streptococcus mutans is responsible for the initiation of the caries. Right, initiation of caries, and the progression of caries is brought about by lactobacillus species. Right. Now, and this, like I said, Streptococcus mutans is one of the most important cause of this early childhood caries, and mostly the Streptococcus mutans is like the child gets the Streptococcus mutans bacteria from the mother. So maternally derived Streptococcus mutans is one of the primary etiological factor of early childhood caries, and maternally derived Streptococcus mutans disease is the synonym of early childhood caries as well because of this reason. So how does the child get this early the Streptococcus mutans from the mother? It is mainly through intimate activities like kissing. That is direct transmission from the mother. Then there is an indirect transmission from the mother as well. That is when the mother tastes the food for the child by using a spoon, and the same spoon is used for feeding the child. So that way, the Streptococcus mutans from the mother is transferred to the child as well. So that is indirect transmission, right? Now, severe early childhood caries is another, the term by itself. Now, severe childhood caries, as asked in this question, it is usually seen in a child of 3 years or younger. Or if it is seen in a child of 3 to 5 years old, then the child should have a DMF score of 4 if the child is the age of 3, and 5 if the child is the age of 4, and 6 if the child is the age of 5. Right. So the presence of any smooth surface caries in a child of 3 years or younger, then it is severe ECC. You don't need to look for any other clues. If the child is 3 years or younger than 3 years and the child has any smooth surface caries, it is severe early childhood caries. Understood. Now, there is we already know that there is a particular pattern of involvement of the teeth in early childhood caries. It is not like rampant caries. Rampant caries is when all the teeth gets involved, but early childhood caries, usually the maxillary anteriors, the maxillary molars, the mandibular molars, and sometimes the canines will be involved, but usually the mandibular incisors are spared because of the protective action of the tongue. So the tongue is there behind the mandibular incisors, which constantly flushes out that area and makes it clean. So usually the mandibular incisors are spared. But in early childhood caries, which is of severe type, that is severe early childhood caries, even the mandibular incisors are affected, as you can see in this particular in this particular question. Okay, so the mandibular incisors will also be affected in severe early childhood caries. So severe early childhood caries is more of a rampant nature of early childhood caries. Understood? Now, right. Now, coming to the next question. The next question is, a child is brought to the dental clinic and the demanding father disregards the dentist's recommendation. What kind of parenting behavior does this illustrate? Okay, so the answer is authoritarian. Now, let's look at the different types of behavior of the guardians or the mother. Usually, children are brought in by mothers, but usually there is a particular pattern of behavior of the parent, and this pattern of behavior of the parent will also be reflected in the behavior of the child. Okay, so there are different types of parental behaviors. One particular type of parental behavior is the overprotective parents. Then we have the overindulgent parent. Then we have under affectionate parent. We have rejecting parents, and we have authoritarian parents. Okay, so all of these terms are more or less self-explanatory in nature. Like overprotective, dominant nature of the parents is when the parent is very much protective of the child, gives everything that the child demands, and it always under the wings of the parents. So how does it reflect in the child's behavior? The child will always be protected by the parents. The child will not be able to take decisions on himself by himself or herself. So the child will usually be shy and submissive to the parents and always anxious. Okay, very indecisive type of behavior. Then we have overindulgent type of behavior of the parents, in which the parent is overindulgent in all the matters of the child. The child is not allowed to take any decisions of his or her own, and this makes the child very aggressive, demanding, and they always throw a temper tantrum in the dental clinic. That is pakka, right? So it is an overindulgent type of parent that makes the child aggressive, demanding, and makes the child throw temper tantrums if something goes against his or her wishes. Then we have the under affectionate, like as the term suggests, these type of parents are very under affectionate. They do not show any affection towards the kid. They are not bothered about the kid. It is not similar to the neglecting or the rejecting parents. Under affectionate is they do not show affection to the kid, as a result of which these children, they will be very shy. They will cooperate. They are usually well behaved, but they do not cooperate with the dentist. They are not able to cooperate with the dentist. They are very shy, and they usually cry very easily. Right. So this is the under affectionate parent that make the child very shy, and the child tends to cry easily. Then we have the rejecting type of parents, where the child is usually parents who do not want children when they have children. That is when the parents exhibit this type of a rejecting behavior, where they do not take interest in the child's welfare and well-being, which makes the child very defensive again, aggressive, and overactive and disobedient as well, because they are usually neglected and rejected by their own parents. And then we have the authoritarian parents, like asked in this question. They are very authoritative. They take decisions on behalf of their children. They constantly they do not regard to the child's terms and child's requests. They do not regard. They have a decision of their own, and they are very authoritative over the children. So these children are very evasive in nature, and they're very dawdling in nature. So in the dental clinic, it will be reflected as the dentist will be telling something, but the parent would have made a research, or they would have done a research on their own, and they will be exhibiting more knowledge than the dentist. They will disregard the dentist's opinions and even their own children's. Okay. So those are the different types of parental behavior which reflects on the children as a specific pattern of behavior as well. Right. Now coming to the next question, DALI, that is disability adjusted life year is. So this is a statistical question, or a question from statistics. So the answer for disability adjusted life year is years of lost life plus years lost to disability. So I'll just tell you the concept of this. This is something that you need to by heart, but I'll tell you the concept of this. Imagine that the life expectancy of a person or a population, like for example, Indian population is 75 to 80, right? Let's say 70. Imagine that this person or this Indian man got a disease or got a handicapped situation at the age of 40 years, right? And he lost his life or he died at the age of 50 years. Okay, so the disability adjusted life year would be the years of lost life to disability. That is, at the age of 40, he got disabled, right? So that year, and years to the life expectancy. That is the years of lost life. And then from 40 to 50 years is the years lost to disability. Both of this together will give you the DALY, right? So it is the year which starts from the disability and the year which prolongs till the life expectancy of a person. So this is the concept of DALY. This is something that you need to by heart. So DALY or disability adjusted life year is the years lost due to disability plus years of lost life. Okay. Next question. Why is water not suitable as a transport medium for owl's tooth? Okay, so we have already studied that avulsion is the complete displacement of the tooth from the socket. So whenever there is avulsion, we have to seek immediate dental treatment. So if the person is not able to seek immediate dental care, that is when you store the owl's tooth in a storage medium in order to maximize the probability of its life, or in order to maximize the probability or improve the prognosis of that replantation of the tooth, right? So we have different storage medium. We know that the most easily available one is the milk. Then we have Hank's balanced salt solution, HBSS. Then we have several other range of storage mediums. But water, which is most commonly available, is not a suitable medium for owl's tooth. This is mainly because it is hypotonic in nature, and this hypotonicity of water causes cell lysis. Okay, so what is hypotonicity? When you say that water is hypotonic, and when you say that there are periodontal ligamental cells in it, so what happens is the water gets transported into the cells because the solute concentration inside the cell is more than outside. So what happens is there will be a diffusion or there will be a transportation of the water into the cell. So what happens is the cell will tend to expand and they lyse. Okay, it does not cause cell shrinkage. It causes increase in the size of the cell due to the transportation of water into the cell, because water is hypotonic in nature. And eventually what happens is the cell becomes larger in size and then it bursts or it causes cell lysis. Okay, so this is why because of the hypotonicity of the water, it causes the cells. What are these cells? These are periodontal ligament cells, which we want to increase the life expectancy of in order to improve the prognosis of a replanted tooth. So what happens is when it is put in water, because of its hypotonicity, it causes the transportation of water into these periodontal ligament cells, which causes an inflation or which causes an increase in the size of these cells, which eventually lead to the breakage or the bursting of these cells or cell lysis. Understood? Coming to the next question, this is an image-based question. So they have given an image and they have given a space maintainer. So they have asked to identify the space maintainer. So this is a lingular space maintainer. So lingular space maintainers is usually used whenever there is a bilateral loss of primary teeth. Okay, there is a bilateral loss of primary teeth. On both the sides, there are loss of multiple teeth. So, it's not feasible to give a long band and loop on either side. So instead of that, we can give a lingular space maintainer. One of the important advantage of giving a lingular space maintainer is that it maintains the leeway space. What is leeway space? Leeway space is the combined mesiodistal dimension of the primary canines and the primary first and the second molars is slightly greater than the combined mesiodistal width of the permanent canines and the permanent premolars. So because of this slight increase in the space, what happens? It causes in non-space dentation, this particular space or the leeway space is being utilized by the molars by a process called late mesial shift to fall into class 1 molar relationship. Understood. So this leeway space is maintained by lingular space maintainer. So that is one of the most important advantage of giving a lingular space maintainer. But before giving a lingular space maintainer, it is mandatory that, or it is necessarily, we have to look for the eruption of the mandibular incisors. Only after the eruption of the mandibular permanent incisors can we think of giving a lingular space maintainer. Okay. So transpalatal arches again. It's similar to lingular space maintainer, only that it is given in the upper arch or the maxillary arch, and distal shoe space maintainer is usually given whenever there is a loss of the primary second molar before the eruption of the first permanent molar. Okay, so that's about the lingular. So like I said, lingular space maintainer, it is a fixed type of space maintainer. That is, it is cemented onto the permanent molars and it is non-functional. Why is it called non-functional? Because there is no teeth that is replacing the lost primary molars. Okay, so there is no masticatory function that is happening, which makes it non-functional space maintainer appliance. And it is usually given whenever there is a bilateral loss of or bilateral multiple loss of primary posterior teeth. And one of the advantage or one of the most important advantage is that it maintains the leeway space. Now, one of the modification that we do while giving a lingular space maintainer is we might put a U loop. Okay, this is the modification. A U loop is usually given in the canine region. Just behind or posterior to the canine region, and this is mainly used for space regaining. Okay, how does it cause or how does it bring about space regaining? It causes the discalization of the molars. When we open up this U loop, what happens is it will tend to push the permanent molars behind a little, which causes the discalization of the permanent molars, which causes the regaining of the space by 1 to 2 millimeters. So whenever we give a U loop or modification of the space maintainer, it can be used as a space regainer as well. And it is very economical and it is less irritating to the tongue if it is properly fabricated. But one of the major disadvantages is that because it has a very long wire or a U-shaped wire, what happens is whenever there is any food material that is stuck in between the wire and the soft tissue, what happens is the child tends to constantly irritate that area with the tongue for the purpose of taking out the impacted food. But eventually it can lead to the disfiguring of the appliance or even decementation of the appliance. So that is another disadvantage of giving a lingular space maintainer. Okay, now next question is, which of the following is a masochistic habit? Okay, masochistic habit is nothing but self-inflicting harm or self-inflicting injuries. That is sadomasochistic behavior, right? So which of the following? It is frenum thrusting. Okay, thumb sucking. All of these are malicious habits, or all of these are very harmful habits, but only frenum thrusting is a masochistic habit because it causes the tear of the frenum. Because of this habit by the child, it causes a tear of the frenum. So that is why it is a sadomasochistic behavior or sadomasochistic habit. Okay, so oral habits can be classified into obsessive habits and non-obsessive habits. Non-obsessive habits are very empty habits, I can say. That is, the child easily learns it, probably due to even boredom, and the child easily loses it as well. Okay, so that is non-obsessive habits. And these non-obsessive habits can again be unintentional or empty habits. And then we have functional habits also. Unintentional is nothing with the chin propping. You have seen a child propping the chin in the forward direction. So it is very unintentional or a very empty habit, which is a non-obsessive habit. The child can be easily or the child can relearn that habit, okay, or lose that habit easily. And it could be functional habits as well, like mouth breathing, tongue thrusting, bruxism, etc. All of these can be easily lost as well. But we have another category of oral habits, which is the obsessive habits, which has a more emotional background to it, or an emotional deep rooted problem, which causes the child to exhibit these habits. And this can be divided into intentional or meaningful habits. And then we have self inflicting injurious habits or masochistic habits. So, one of the masochistic habit is frenum thrusting, like we already discussed here, or gingival stripping. Okay, this can also be self inflicting, and this is a sadomasochistic habit or a behavior. Then we have intentional or meaningful habits, which could be thumb sucking, lip biting, or nail biting even. So whenever a child comes to you with a thumb sucking or any other oral habit for that matter, the first and the foremost thing that we have to do is identify the cause behind it, and then we have to treat the cause rather than the habit alone. So because each of these habit might come out with an emotional baggage, right? So, sadomasochistic behavior is self inflicting injurious habits. Next question, 2-year-old child was brought to a clinic with spacing. Okay. Dentist noticed spacing mesial to the upper canine and distal to the lower. That is distal to the lower canine. What you should do. So, what you have to see here, first of all, the child is a 2-year-old child. Okay, by 2 years, almost all the primary teeth would have erupted into the oral cavity. Okay, so the child has primary dentition now, and when the child is brought to the dentist is noticing a particular type of spacing that is present mesial to the upper canine and distal to the lower canine. So, what should be done? Should we give crowns to close the space? No. Should we give restorations? No. Should we extract? Definitely not. What we have to do? Wait and watch. Why? Because these spaces are normal spaces or primate spaces. Primate spaces are those spaces. In space dentition, these primate spaces are seen lateral in between the lateral incisors and the primary canines in the upper arch, and in between the primary canines and the first primary molar in the lower arch. And these primate spaces, they actually provide the space for bringing about class 1 molar relationship in a spaced dentition with a flush terminal plane. So these are very normal spaces, and you just need to wait and watch. There is nothing else that needs to be done, as it is a very or it could be it is a self-correcting anomaly. It's not an anomaly, it is a very normal spacing that is usually seen. Now, next question is, following pulpectomy of the primary first and the second molars, the appropriate sequence for crown placement is as follows. Okay, so among the option, the answer is placement of the crown in the second molars first, followed by the first molar. So whenever we are placing crowns, as a rule, remember that first we have to start from the posteriors, and then only you have to continue in the anterior direction. So the first crown to be placed is definitely the posterior crown. That is the second molar crown, followed by the first molar crown. Okay, it's a very straightforward question. Next question, this is also a very straightforward question. Diagnodent. Diagnodent is used for what? Is it for treating carious lesions? No. Prevent carious lesions? Yes and no. I will explain it to you. Diagnose carious lesions? Yes. And remineralize the carious lesions? No. Why I said yes and no for preventing carious lesions is, first one, it is a very direct question. There is nothing to brainstorm about it. Diagnodent is a investigatory or a diagnostic material for carious lesions. Now, when we diagnose these carious lesions, especially in the initial stages, it can thus help in preventing further progression of the carious lesions. That's all. It is not used for preventing the carious lesions. It is used for diagnosing the carious lesions at very early stages even, so that further progression of the carious lesions can be prevented. Okay. So diagnodent is an investigatory or a diagnostic material or a diagnostic machine for for the carious lesions, right? Now, next question is, two 11-year-old girls, one attained menarche and the other didn't. Which one is considered for functional appliance therapy for mandibular retrusion correction? Now, this is a very it's not a difficult question, but it is a very confusing question. Two 11-year-old girls, okay, both of them are 11-year-old. One has attained puberty, one has not attained puberty, which is considered for functional therapy for mandibular retrusion correction. So these girls have mandibular retrusion. So that has to be corrected. So by 11 years, the correction of mandibular retrusion is usually achieved by advancement of the mandible in the forward direction. So some amount of myofunctional therapy or some form of myofunctional therapy has to be given. Now, please keep this in mind. If you go into detail, it is going to be very difficult, and I don't think that it is at this particular level, you don't have to go very deep into it. Myofunctional therapy is usually done during the prepubertal age, okay, or the circumpubertal age, I would say. Circumpubertal age, why? Because of the growth spurt, okay. Children tend to grow or exhibit an acceleration of the growth, okay, during the growth spurt period. And one of the growth spurt period in children is the circumpubertal or around the puberty. Okay, so if you brainstorm and think about it, both of these children can be taken up for myofunctional therapy, but definitely the one that has not attained puberty still has more potential for responding to therapy than the other one, because the first one has already started declining. That is, once puberty is attained, then the peak of the growth or the peak of the skeletal growth starts declining from puberty. But for the other child, puberty is not yet reached and still on the peak of skeletal growth. So that is when we apply myofunctional therapy, which can bring about a mod or which can modify the growth pattern. So definitely the one that has not attained puberty or around the puberty or circumpubertal age is when you give myofunctional therapy or when it uh, best responds to myofunctional therapy. So according to that, the second girl is the option or the correct answer. Okay, so I can just tell you something about cervical vertebral maturation stage as well, but it's a little complicated, but you just have to keep this in mind. There is a particular staging that is usually used for identifying the skeletal age of a child. So one of it is hand wrist radiograph, like you have already studied in your orthodontics, and another one is cervical vertebral maturation stage. That is looking at the pattern of growth of certain cervical vertebrae. Okay, especially cervical vertebrae, second one, third one, and the fourth one. By looking at the shape and the growth of these cervical vertebrae, we can predict the skeletal age of the child. Okay, so accordingly, the cervical vertebral maturation stage can be divided into 6 different stages. Okay, so let's call them CS1, CS2, CS3, CS4, CS5, and CS6. CS1 and 2 is the initial or the prepubertal stage. CS3 and CS4 is the circumpubertal age. CS5 and CS6 is postpubertal age. So the best region or the best stage where we can go for a myofunctional therapy is definitely CS3 and CS4. That is circumpubertal age. That is when the growth spurt happens, and that is when the myofunctional therapy or the child responds to myofunctional therapy the best. Okay. Right. Next question. A child comes with a pink tooth. So what is a pink tooth? It is nothing but internal resorption, and it is mostly bacterial because it is caused by bacterial invasion. Okay, what happens is from the pulpal space or even from the periodontal space, bacterial infection can get into the dentinal tubules and cause the internal resorption of the tooth. Because there is internal resorption and because of the dentine getting eaten away, what happens is the pulp gets the tooth or the enamel gets translucent, and the pink color that you can see is the pulp that is showing through the thin enamel, and mostly this internal resorption is caused due to bacterial agents, right? Next question. A 3-year-old child has multiple enamel caries in the front teeth. Which of these restorations would cause the best fluoride recharge? Now the answer is RMGIC. Among the four, the best for a child of 3 years of age and which causes the best fluoride recharge would be RMGIC. comparing the technique sensitivity also in a 3-year-old child, RMGIC is the most practical option, and thus RMGIC is the answer. Now, when restoring a maxillary canine with an Ellis class 1 fracture in a 12-year-old using a composite material, what consideration should be taken into account? Okay, so the answer is short mesial cusp ridge. Now, this is again a confusing question. They have given very unnecessary information about this. Like, first of all, they are saying that it's a class 1 fracture. Second of all, they are saying that it is a 12-year-old. They just need to ask what is the consideration for giving a composite restoration in a permanent canine, because we know that in permanent canine the mesial cusp ridge is short as compared to the distal cusp ridge, and always it has to be given short. That's all. Okay, so that is also a very straightforward question. That's it about today's session. I hope that it is clear. If you have any questions, you can always reach back to me. I'll try to answer it. And if there is any doubts now, you can go ahead and ask me. Please unmute and ask me. I hope there are no questions. I hope it's clear. So I'll come back with another discussion later. You can always reach back to me and I'll try to answer your queries. Thank you, everyone. Good night. Thank you.